So in chronic leukemia also we have myeloid and we have lymphocytic leukemia. So now dukoresha lymphoblastic kwa kusereza mu ntabwo ari lymphoblastic, they are mature. That is the main difference between the chronic and acute. In acute you have a blast, while in chronic you don't have a blast. You have more differentiated cells. Kibazo nuko zabaye nyinshi cyane. But you have other conditions, myelodysplastic syndrome and so on, as we shall see, which are listed among the chronic leukemias sometimes. So chronic lymphocytic leukemia is the first category we are going to see. So here on this blood film, peripheral blood film, you can see red blood cells, and then we see some lymphocytes here, which are relatively mature. They have the cytoplasm can be seen. So there will be proliferation of naive B cells that co-express CD5 and CD20, most common, and this is the most common in leukemia overall. So it's the most common, and it is seen mainly in adults. So there will be increase in lymphocytes, and the smudge cells are seen on the blood smear. So smudge cells, crushed. Involvement of lymph nodes leads to generalized lymphadenopathy and is called lymphocytic, small lymphocytic lymphoma. Okay, nkera ahangaha nkibyibukana no kuri acute lymphoblastic leukemia, navuze ko hari ubwo ibi associated with lymphoma. Lymphoma yayo bayita lymphoblastic lymphoma. So they share many all things are the same, mutations and so on. So in the WHO classification, ni indwara imwe, and acute lymphoblastic leukemia / lymphocytic lymphoma. It is one disease. It can present itself as either a leukemia or as a lymphoma or both. So the same for chronic lymphocytic leukemia, it is the same entity as a small lymphocytic lymphoma. So in the WHO classification, they write chronic lymphocytic leukemia / small lymphocytic lymphoma. So the implications include hypogammaglobulinemia, and the consequence is that because someone having not enough gamma globulin, they are more prone to develop infections. That's the most common cause of death in these people. So they also develop autoimmune hemolytic anemia, and sometimes they have a transformation to diffuse large B-cell lymphoma. So these cases, I saw some cases at our hospital where a patient had chronic lymphocytic leukemia or small lymphocytic lymphoma, and then afterward, they develop a very aggressive tumor, which is diffuse large cell lymphoma, we shall see it. So there is another condition, another leukemia called the hairy cell leukemia. In the cytoplasm, there are things which look like hairs. Cytoplasm of each cell. Hairy cytoplasmic processes. So they are positive for tartrate-resistant acid phosphatase. Clinical features, usually these patients they present with splenomegaly, because these cells, the hairy cells, will be cultured by red calf in the spleen. So sometimes, usually they don't have lymphadenopathy or lymph node enlargement. So here they respond very well to this treatment, cladribine and the adenosine deaminase inhibitors. So this help much in these patients. So adult cell leukemia or lymphoma, it means these patients also they can develop a leukemia or a solid tumor lymphoma. And these ones, their problem is proliferation of mature CD4 T cells. So it is associated with this human T cell, human T lymphoma virus type 1. I remember we saw this in neoplasia and general pathology. more seen in Japan and the Caribbean countries in America. So there you have a rash, skin rash, nkuko mubona umuntu afite uduheri twinshi tudakira ukagira ngo wenda ni allergy, ariko ugasanga nubwo wamuha imiti ya allergy ntacyo bigabana. So you see here this figurement here. So they have a generalized lymphadenopathy, lymph nodes everywhere with hepatosplenomegaly and lytic bone lesions with hypercalcemia. So this lytic lesion, we see them in that disease, multiple myeloma. Infiltration of the bones, so they destroy bone in multiple foci, giving rise to this punched out bone lesions. And then because the bone is destroyed, calcium will be increased in the blood stream. So mycosis fungoides, the name here doesn't show that it is a cancer. This is a cancer derived from T lymphocytes. It affects skin. So when there is a T cell lymphoma affecting the skin, we call it mycosis fungoides. So there will be an neoplastic maturation, proliferation of mature CD4 T cells which infiltrate skin, and they produce skin rash, plaques, and sometimes the nodules. So aggregates of neoplastic cells in the epidermis are called Poutrier microabscess. So Poutrier is a French man who described that for the first time. So the cells can spread to involve the blood. It will give Sézary syndrome. And here you can see Sézary cells. So it is this abnormal lymphocytes seen in the bloodstream. Otherwise, when it is not involving the blood, it will just be called mycosis fungoides. When blood is involved, then Sézary syndrome. And this means that if someone is diagnosed with mycosis fungoides, you have always to check if blood is not involved. So that is for chronic leukemia. You saw that we didn't see myeloid leukemia. Chronic myeloid leukemia is specifically classified among myeloproliferative disorders, MPDs. So this is the proliferation of mature cells of myeloid lineage. You can understand there are myeloid neutrophils, basophils, eosinophils, monocytes, red blood cells, megakaryocytes, all this. So among them, this disease affects the adults, and we have the list here. We have a polycythemia vera. This is when someone has a lot of red blood cells. I had mentioned timony and essential thrombocythemia and the myelofibrosis. And then you have a chronic myeloid leukemia. So this table here is showing them according to the mutations which are seen there. So JAK2 mutation is seen in these three, while BCAR-ABL1 fusion gene or Philadelphia chromosome is seen in chronic myeloid leukemia. So usually there are very high white blood cell counts. So I remember in the patients I had in the course of my research projects, so I was after 400,000 red white blood cells per microliter, and one normal action. So the cells of myeloid lineage are increased, classified based on the dominant myeloid cell produced. So complications, there is a risk of hyperuricemia, gout due to high cell turnover, because there are so many cells in the blood. So there are also so many cells which will be killed, especially in the spleen. And when they are killed, so there will be uric acid which will be produced, and that one will be the origin of this hyperuricemia. Sometimes they can progress to marrow fibrosis. So bone marrow fibrosis means there are no longer hematopoietic cells in the bone marrow. You just find the fibers. You just find the fibers So you can understand that the consequences in that scenario, there will be leukopenia in general, because the bone marrow, which was supposed to produce the hematopoietic, the blood cells, is fibrotic. It has no longer any stem cells. Another possibility, there is a transformation into acute leukemia. It is possible, and we have some cases here. So, starting with chronic myeloid leukemia, and we have a proliferation of mature myeloid cells. You can see them here. They are mature because they have a band. You can recognize that the nucleus is having many lobes. When it is acute myeloid leukemia, you don't find the lobes. They look like lymphocytes. But you have the lobes, and the cells are many, of course. So this is chronic myeloid leukemia. Here we have one cell which is relatively immature. So this is driven by the mutation in T922. So translocation between chromosome 9 and 22. So ikibanga nuko hari agace kamwe kava kuri chromosome 9 akandi kuri 22 bigahura bigakora a new, what you can call a new chromosome, which was called the Philadelphia chromosome. Maybe the meeting which approved that took place in the city of Philadelphia in Pennsylvania in the US. So then the result is that there will be a fusion protein of BCR ABL. So I think ABL comes from 9, while BCR comes from chromosome 22. So there will be increased tyrosine kinase activity. Tyrosine kinase, remember it in a cell transduction. Kuri receptors have a second messenger as the nucleus. So we have a G-based protein, things like that, and you have a tyrosine kinase. These are the two main mechanisms for cell transduction. So our abarwayi have a treatment, imatinib, which will block the tyrosine kinase activity. So what I can say is that we have started to make this molecular testing, if you can say so, a few months ago at Africa. So we are the first center in Rwanda to do that molecular testing on cancer patients in the country. So it is a study which is funded by Africa itself. So we are a group of people working on that. So what you wanted is to, first of all, to show the feasibility using the available machines. Dukoresha za machine zisanzwe zipima vya tuberculosis, gene expert. Kono muri yo zikora tuberculosis zirebamo there some mutations. So nizo dukoresha. So we bought new reagents used to detect this transcript. So and another reason we do it is that normally this test should be done not only for diagnosis but also for follow-up. Niba umurwayi bayimusanzemo yari afite mutation, translocation, bakamuha imatinib, nyuma y'amezi runaka bagombye kongera gupima bakareba yuko if there is a response. When there is no response or a poor response, then you change the drug. You give a second level treatment. So that is our aim. It is what we are doing. So there are patients who are enrolled. They have been tested for this transcript. Then they continue to receive treatment because this treatment is available in Rwanda. So then we do follow up after periodic follow-up to see if now the cancer cells have decreased. Where they don't decrease, then we recommend to change the treatment regimen. And I think it will help much. And we are lucky because we are dedicated to that. So the Ministry of Health last year, they issued a new tariff for medical acts. So they have included also that in medical act. So meaning that even medical insurance says they will cover that. So we think it will continue to help patients. So clinical signs of people affected by chronic myeloid leukemia, there is a splenomegaly, enlarged spleen. And this can suggest accelerated phase. So I have not talked about this. So in chronic myeloid leukemia, habamo chronic phase. Ni ibisanzwe aho akenshi nta n'ibimenyetso byinshi haba clinical signs. Then hakaza accelerated phase, ni ukuvuga harimo many blasts, so there is a high possibility of having transformation into acute myeloid leukemia, which is very deadly. Then hakaba niyo bita blastic phase, none igihe zabaye nyinshi icyo gihe metablastic phase of chronic myeloid leukemia. You will confirm that it is a real transformation into acute myeloid leukemia if you find the mutations which are specific for acute myeloid leukemia. So you can see that when it transforms into cancer, into higher grade of leukemia, it will transform into acute myeloid leukemia, but also in acute lymphoblastic leukemia. So it is like bitumvikana ko ari myeloid ikabyara lymphoid. So it is not because there's a myeloid cancer, myeloid cells will transform into lymphocytes, but the lymphocytes also will get a mutation, then develop their own cancer. So ntabwo ari serire za CML zandikamo ALL, ahubwo the normal lymphocytes which were there may be mutated in bone marrow, of course, and then produce an acute lymphoblastic leukemia. So CML is distinguished from a leukemia reaction leukocyte, who afite many myeloid cells or leukocytosis. Ugomba kubyitondera ntuhite uvuga ngo afite chronic myeloid leukemia, because this is a terrible diagnosis, a cancer. So you must exclude other possibilities. When it can be a leukemia reaction, no kuvuga umuntu yagize a lot of myeloid cells, which can suggest that it is leukemia, but it is not leukemia. So there are tests here to confirm if it is leukemia or not, including that translocation. Polycythemia vera, so in overproduction of red blood cells, ikibitera mwahita mubyumva nuko erythropoietin iba yiyongereye. Erythropoietin ishobora kwiyongera mu kubw'impamvu nyinshi, harimo no kuba murabizi ko ni hormone ikorwa muri kidneys. So if a kidney is having a tumor like renal cell carcinoma, I think last time we talked about that when we saw the urinary system. So if there is a tumor of the kidney, it will produce too much erythropoietin. Then with too much erythropoietin, the bone marrow will be stimulated to make a lot of red blood cells. So the red blood cells there themselves, they don't look like a cancer cells. They don't have a nuclei. They are just there, but they are remaining. So the main problem is that because there are so many, the blood will be hemoconcentrated. And you can understand there will be risk of making rurals or groups of red blood cells. And as such, there will be occlusion of small vessels and so on. So the patient will have fatigue, headaches, dizziness, episodic blood vision, peripheral tingling or burning and itching, hypertension, and so on. So mucosal cyanosis, bruising, petechiae, bruising and petechiae. So this is because there is a hemorrhage. In that case, the platelets will be decreased. So it can be primary if the mutation is in the JAK gene, which will cause unregulated cell division. It can be secondary when there is an underlying condition such as tissue hypoxia, kidney diseases, and hormone-related medications, which can trigger the production of a lot of red blood cells. So treatment rero nta yindi no phlebotomy no kuvuga no kureba venes zimwe ugateramo urushinge amaraso ukayavudura. So urumva ni ikintu wakora ahantu ari hose, gusa nyine ntuyamaremo kugira ngo atava muri shock. So you must know how to deal with that. So in hematology you have more details on how to ensure you remove an adequate volume of blood. So nka bya bintu by'abanyarwanda bita kurasaga, ni ukuvuga umuntu ayifite nk'uyu ukamurasaga, kuko kurasaga bivuga ko umuntu umukomeretsa amaraso agatakara. There will be improvement of the signs and the symptoms. So there are that treatments here. So uzamuha amazi kugira ngo nibura akore hemodilution kubera ko ubwayo red blood cells atera hemoconcentration. So platelets and the granulocytes will be sometimes can be increased associated with that mutation, this we say, and then the signs and the symptoms. So treatment, we said it, phlebotomy and so on. So you must also distinguish polycythemia vera from reactive polycythemia. So for example, here it is said that, so there's a mistake. This also will be a capital. In polycythemia vera, the erythropoietin levels are decreased. No kubera iki niya mechanism ya feedback mechanism kako red blood cells zabaye nyinshi umubiri uzahita wibwiriza ugabanye erythropoietin. And the saturation of oxygen is normal. In a reactive polycythemia, due to high altitude or lung disease, the saturation in oxygen is low and the erythropoietin is increased. So there are other differences here. So yangwe murabizi uko umuntu aba muri altitude hejuru abateye mu misozi yo hejuru baba bagomba kugira red blood cells nyinshi kubera ko hari abari bisa naho oxygen iba ari nke kuba ari nke rero bituma bakenera more red blood cells kugira ngo zitware that small amount of oxygen which is around the day. So niyo mpamvu ufasha abantu batuye mu misozi miremire ukagira nyiratuye mu bibaya nka Bugarama ntabwo bazagira normal ranges of red blood cell count. So essential thrombocythemia, I think you can understand thrombocythemia, thrombocytes or platelets are much increased. There is a proliferation of myeloid cells, especially platelets. Ntabwo nzi niba mwarize hematology, and hano mwari kunyereka platelets izo arizo. So here we have red blood cells, here we have a myeloid cell. So platelets ni utu tumeze nk'imyanda turimo hano inyuma. So iyi ntabwo ari imyanda, these are platelets. So izi rero ni nyinshi kuzira hano, ubundi uba ukabona kamwe na kandi iriya, kandi ari duto ariko utunini kandi ni twinshi. So nicyo iyo ubibonye gutya rero uhita wakabona marrow biopsy cyangwa urebemo uko bimeze. Urebemo niba megakaryocytes zarabaye nyinshi and so on. So they are associated with JAK2 mutation, kinase mutation. So symptoms are related to increased risk of bleeding and or thrombosis. So twakwibaza ngo kubera iki bagira bleeding kandi bafite platelets nyinshi. Izi platelets nubwo ari nyinshi nkuko nabivuga, they are not in normal forms. Bivuga ko zitazakora umurimo wazo uko bikwiriye. Otherwise ntabwo yagombye kugira risk of hemorrhage, aho wenda yagombye kugira risk of thrombosis because of this increased platelets. But that risk of thrombosis also can exist, especially if the platelets produced here are normal. So they can progress to bone marrow fibrosis and the acute leukemia. So myelofibrosis, so this is a bone marrow tissue. This is abnormal, of course. Tubonamo bone trabeculae noneho zikikijwe na hematopoietic cells. So here we don't see hematopoietic cells. We are seeing other things, fibers and so on, and probably inflammatory cells. So it is a proliferation of mature cells, especially megakaryocytes. So they produce a lot of platelet-derived growth factor that we saw in healing and repair. Mu bituma habaho formation of scar fibrosis. So rero nibyo bituma habona fibrosis muri bone marrow. Then curiously abarwayi baba bameze nk'abafite leukemia. Signs and symptoms. I remember there was a case, so they sent a biopsy to me, bone marrow. Then I thought this is myelofibrosis most likely. N'ubu hari test twagomba kuba twakoze ariko zidahari. But I say this is likely myelofibrosis. So the hematologist from another center, so said he was not. Uh, so he didn't accept that. So he called for the slides to see them himself, and then he sent the slides. So he confirmed it was myelofibrosis. But the clinical signs, it was as if the child suffered from a severe acute leukemia. But it was like this. So they have a splenomegaly and extramedullary hematopoiesis. Because the marrow tissue is no longer there for hematopoiesis to take place, then the consequence is that hematopoiesis will take place in the other organs, usually in the liver and spleen and so on. So leukoerythroblastic smear, here it is showing a drop. Here drop red blood cells. Kimeze nk'igitonyanga cy'amazi cyangwa cya fluid. Here drop. Sometimes they have a nucleated red blood cells. Izo ubona zidafite whitish center because zifite nucleus. So they have captured their nucleus, which is abnormal. So this they have a risk of infection, thrombosis, and bleeding. So we proceed with lymphoadenopathy. If you have questions, you can ask them, otherwise we proceed. Okay. So no question, then proceed. So lymphadenopathy ni term ikoreshwa ushaka kuvuga gusa ko umuntu afite enlarged lymph node. So it is not a diagnosis, ni nka syndrome. Umuntu ashobora kuba afite lymphadenopathy y'ubwayo ari leukemia cyangwa lymphoma irimo, ishobora kuba ari infection such as tuberculosis and so on. So that's why when you diagnose, you said someone is having lymphadenopathy, it is not a diagnosis, but it of course it helps you to narrow down the possible consequences. It can be a primary cancer, lymphoma, or leukemia. It can be an infection, or it can be a metastatic cancer. Maybe cancer of prostate, cancer of the breasts, or any other cancer coming to the lymph nodes. So lymphadenopathy refers to enlarged lymph nodes. So it can be painful or not. So painful lymphadenopathy is seen in lymph nodes that are a draining region of acute infection. While painless lymphadenopathy can be seen with chronic inflammation or metastatic cancer or a lymphoma, primary lymphoma in that lymph node. So you can understand ibi bizabafasha none umuntu afite lymph node uzamubaza niba iyo ukoze palpation bimurya, niba bimurya, then you orient yourself what I'm looking for. If it is painless, ngira ngo bizaba ari ibibazo nyine birumvika. So in inflammation, lymph node enlargement is due to hyperplasia of particular regions of the lymph node. So usually we have germinal centers, and also we have the parasinuses, which are increased in size. So follicular hyperplasia ni lymph node germinal center. Paracortex hyperplasia is where T cell live. Is seen in viral infections such as infectious mononucleosis and so on. So hyperplasia of the sinus histiocyte is seen in lymph nodes that drain a tissue with a cancer. So here in this diagram, there are potential causes, local or systemic. I think they are the same as we mentioned. So then this prepares us to go further to lymphomas. Lymphomas, which are solid tumors now arising from lymphocytes. So this is a neoplastic proliferation of lymphoid cells that forms a mass. It may arise in a lymph node or extra lymph node tissue. So harimo ibice bibiri rero, we have what we call Hodgkin lymphoma and non-Hodgkin lymphoma, and there is a table afterwards which compares them. So the non-Hodgkin lymphoma are the most frequent compared to Hodgkin lymphoma, but unfortunately non-Hodgkin lymphoma is the most aggressive one. So but Hodgkin lymphoma, they are treated and they respond, except some subtypes are usually. So non-Hodgkin lymphoma is further classified based on cell type, either T cell or B cell. Also, when you look at cell size, niho havuzamo ngo diffuse large B cell. Large B cell when it is large. Or it can be small cell. Small lymphocytic lymphoma. Also, we look at the pattern of cell growth and expression of surface markers, cytogenetic translocations, where they can do them. So urebye kuri size rero hari small B cells, which are follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, and small lymphocytic lymphoma, yani twabonye muri chronic lymphocytic leukemia. So we have intermediate sized B cells. This is mainly seen in bucket lymphoma, ariko harimo na lymphoblastic lymphoma, lymphoblastic leukemia, nayo niko zari intermediate. So the large cells, we call them large B cells. When it is B cell, of course. Kuko dufite na anaplastic large cell lymphoma zo ni T cells. Nazo tunazigira nubwo atari nyinshi. So staging, you are familiar that staging of cancers uses TNM staging, tumor, primary tumor, lymph node, and metastasis. In lymphoma, it is not the case. It is not the case. So the staging system which was proposed ni irahangaha. So it is called the Ann Arbor system. Ann Arbor is a city in the United States, I think. Muri cya gice cy'ibiyaga bigari hejuru muri leta ya Michigan cyangwa se, yeah, I think it is Michigan. Muri leta ya Michigan niho habereye inama yemeza staging. So how do we stage lymphomas? Ikindi navuga nuko iyi staging yabaye developed for Hodgkin lymphoma. Nyuma basanga n'ubundi no kuri non-Hodgkin lymphoma nta yindi bakoresha, barayadopta, ariko it was designed for Hodgkin lymphoma. So how do you stage lymphomas? When a patient is having a lymphoma in one location, kuri lymph node imwe cyangwa se lymph node zegeranye ziri ahantu hamwe zifatanye zabaye mate, icyo gihe ari stage 1. Uko haba ari kinini kose cyangwa gato kose. It becomes stage 2 iyo ibyo bifashe region ziruta uduce tw'umubiri turuta kamwe, ni 2 ni 3 ni 4, ariko biri kuri one side of the diaphragm. You see here. So nubwo yari gufata agisira zombi na neck, ariko biri byose nyine bikaba biri hejuru ya diaphragm ya stage 2. Iba stage 3 iyo regions ziri on both sides of the diaphragm, hasi ndetse no hejuru ya diaphragm, iba stage 3. Noneho stage 4 iba ifata izindi organs. So wasanga ageze muri ifata na spleen, ifata liver nkuko hano bigaragara, cyangwa se ifata no muri bones, especially bone marrow. In that case it will be stage 4. Stage 4. So muri staging twongeraho inyuguti A na B. A ni uko kamanze B. B ivuga ibyo twita B symptoms. B symptoms ni ibimenyetso nk'ibya umuntu urwaye tuberculosis. So no kugira sweating, especially during the night, no kugira umuriro udasobanutse, gutakaza ibiro mu buryo budasobanutse, gutakaza appetit, ibyo anorexia. So ibyo ngibyo mu murwayi bifite tubaho afite B symptoms. So even when niyo ndi gukoreza ndi gusuzuma umurwayi afite lymph nodes, ibyo byanze kuza ndabimubaza. Namubaza ubona ibiro bya byaratakaye, hangaye ko ati ngiye mu kwezi kumaze gutakaza ibiro 5 aho ese watakaje appetit, ese ugira umuriro kenshi, kuko ushaka kuma kwa ufite ariko agenda wigira ugaruka ugenda ugaruka. so no kugira ibyuya bya nijoro. So iyo ubonye afite na kimwe muri byo uvuga ko afite B symptoms niyo utaramenya niba afite lymphoma, ko hari igihe usanga nyuma uza gusanga ni tuberculose, tuberculosis, so ntacyo biba byishe n'ubundi kuko signs zimeze. So this is the Ann Arbor system. So the warning signs of lymphoma are fever, swelling of the face and neck, lump in your neck, armpit or groin, kuko muzi ko baba lymph nodes cyane ahangaha, ariko hari abarwayi bamwe na bamwe bagira large lymph nodes internally, akaba yifite para-aortic, hari uyigira muri mediastinum. So I remember we had the cases in like 2014 at Africa. We had the case yari afite pleural effusion, so twafatamo fluid ntitubonemo cancer cells ariko bikekwa ko afite cancer. So so there was an American, so he asked me if I can do the aspiration in the mediastinum. So I said, so okay, under CT scan guidance I can. So I did with a resident. So we got the cells, and the cells were exactly looking they are lymphoma cells. So because it is known that the mediastinum, when there's a lymphoma, it cannot be B cell, it is always T cell, so they treated as T cell lymphoma in that case. So ntabwo yari afite axillary lymph node cyangwa groin and neck, zari ziri mediastinum. So it happens. So basic principles when you compare non-Hodgkin lymphoma and Hodgkin lymphoma. So non-Hodgkin lymphoma is the most prevalent. The malignant cells are lymphoid cells in non-Hodgkin lymphoma. While in Hodgkin lymphoma, they are red Steinberg cells. We shall come back on that. These are also have been discovered. They are B lymphoid cells. Ariko abantu babijyaga harimo akangaho no they are macrophages and so on, but at the end they concluded they are B lymphocytes. So the composition of the mass in non-Hodgkin lymphoma, they are just lymphoid cells. While in Hodgkin lymphoma, ubonamo cancer cells nke ahubwo izi nyinshi ni reactive, cyane cyane eosinophils. So many eosinophils. Clinically, both of them they are painless. Hodgkin lymphoma is usually with B symptoms, and affects younger adults, while non-Hodgkin lymphoma affects adult patients. So the non-Hodgkin lymphoma, it is spread very easily. It affects many areas at the same time. So you understand that its stage at diagnosis is usually high, as compared to Hodgkin lymphoma. Usually, Hodgkin lymphoma affects one area, and usually they are just a lymph node, while non-Hodgkin lymphoma affects often other tissues other than lymph nodes. So the staging, as I said, the Ann Arbor is more useful for Hodgkin lymphoma than non-Hodgkin. Leukemic phase, meaning that a patient with leukemia can develop also leukemic cells or malignant cells within the blood stream. So it exists in non-Hodgkin lymphoma, but never in Hodgkin lymphoma. So ngira ngo hari n'ibindi byinshi. EBV, Epstein-Barr virus, is more involved in Hodgkin lymphoma than non-Hodgkin lymphoma. Abantu bafite HIV/AIDS nubwo bagira risk iri hejuru yo kugira lymphoma iyo ari yo yose, ariko iyo bagira nyinshi ni Hodgkin lymphoma. So this is one of the examples of non-Hodgkin lymphoma. It is follicular lymphoma. So bagira mutation, a translocation between chromosome 14 and the 18. This is a characteristic, and I think this we must keep in mind. Ikibazo cyacu rero kibera kuri BCL2. If you remember what you saw in apoptosis, this gene is very important in the regulation of the apoptosis. I think this is pro-apoptotic, akawindi kwa back to your anti-apoptotic, or vice versa. So treatment is reserved for patients who are symptomatic. So personally, I know these cases are very few in our settings, and it as written here, not all of them they will be treated. They treat those who have symptoms. So what we have to do on histology, that is for pathologists, ni ugutandukanya follicular lymphoma na follicular hyperplasia. Kuba follicles zabaye nini kubera reaction, kubitandukanya na lymphoma, that is our task. Because ushobora kuvuga ngo umuntu afite lymphoma kandi atayifite kubera ko utandukanye. So this is maybe our concern. So mantle cell lymphoma. So this brings back to the to the anatomy of the lymph node. So in a lymph node, we have a germinal center, which is in the center of each follicle. It is surrounded by mantle zone. Then the marginal zone is the most external part of it. So then this mantle zone can have a lymphoma just arising from the cells here. While a cancer from germinal center near the follicular lymphoma. And then we have also what we call marginal zone lymphoma, which is the option. So here we have a translocation 11 to 14, which is more seen, especially cyclin D1 gene, which translocates to IG, heavy chain locus on chromosome 14. So marginal zone lymphoma again. So after mantle zone, we have marginal zone lymphoma rising from the cells of the marginal zone. So there are B cells, small ones. Ikigaragara nuko ikunda kugaragara ahantu hari kwapitari because. So hari tureba thyroiditis, abantu bafite Hashimoto-thyroiditis nuko bafite lymphocytic inflammation in the thyroid. Iyo itavuwe bafite risk yo kugira lymphoma. So lymphoma, they are lymphoma, then it is a kind of marginal zone lymphoma. Cyangwa n'abantu bafite H. pylori gastritis, which is, it is of course a chronic, but when it is long-standing, it can cause problems, either carcinoma or lymphoma. When it is a lymphoma, it is only multi lymphoma. Cyangwa se mucosa associated lymphoid tissue lymphoma. So it is a kind of marginal zone lymphoma in the desert mucosal sites. So the famous bucket lymphoma that I have mentioned when we saw neoplasia, yavunayivuzeho byinshi ni kanseri yabonetse umuganga witwa Bucket, Dennis Bucket w'umwongereza ari muri mission muri Uganda, hanyuma mu myaka y'1958 abona abana bafite ibibyimba bimeze gutyo benshi, arandika ati jye nabonye igisarikoma mu bana b'Abanyafurika b'utwana imyaka 7 aho ngaho, ati kidasanzwe n'ubwa mbere gibonye. He published. So yavuga sarikoma kuko yabonaga yose atari carcinoma. Ntabwo byari lymphoma icyo gihe byari biramenyekana. Nta lymphoma zari zizwi rero. So he took biopsy yango ni story nababwiye, he took specimen ayohereza mu Bwongereza iwabo. So yari umumisiyoneri n'abana n'amadini. So specimen itinda mu nzira, indege yajyanye uzi exactly icyabiteye, ariko specimen yageze muri labo yayoherejemo nyuma y'imisi 71. So bigerayo bifite sign yuko hari ikintu kiri infectious kubera uburyo byagaragaraga bimeze nka purulent and so on. So barabipima bati nta kibazo, turabipima turebe. So barapima basangamo harimo virus. That virus, it was the first time to see it. So laboratoire yari ikorerwamo n'abantu bari witwa Epstein n'uwitwa Bar n'uwitwa Achong, noneho virusi yitirirwa ababiri ba mbere undi ntibamusiramo. So that I said. Then barebye neza basanga nta nubwo ari sarcoma, ahubwo amaseri yayigize ntabwo ari spindle cells, ahubwo ni lymphocytes. So this is the first time to see this kind of lymphocytes. So bahita bayitirira wa muganga wabibonye bwa mbere Bucket, Dennis Bucket. So iyo urebye amateka yabyo, so I have read many things about this, and so hanyuzemo ibintu byinshi, ubushakashatsi bwinshi, Abafaransa bagizemo uruhare, abo muri Sweden bareba cyane bya molecular mutation zone bya translocation ibamo chromosome 8 to 14 nibo bayibonye, so bakoze ibintu byinshi ku buryo ari bisa naho ari nabwo bwa mbere hari habonetse kanseri iterwa na infection. Ibindi ntabwo bari baramenya ko gastric cancer ishobora guterwa na infection, so bituma ikorerwa ubushakashatsi bwinshi. So ibyo navuga byabayeho muri iyo myaka 1958, 1962, ngira ngo n'amateka y'igihugu cyacu mu buhuza n'ibintu byabaga hano mu Rwanda. Icyabayeho ni iki? Abashakashatsi bararebye basanga abana bo muri Uganda nibo bari kubigira, ariko bati none se impunzi z'abanyarwanda ziri kugera hano nazo zo muri aje kuki bo batari kwirwa. So murabyumva, abantu reka tubita ababyeyi bacu ubu ngubu bari bariyo icyo gihe nibo bagiye ari abana bavutse muri 57, 55 bari abana nabo bashaka gufatwa nayo. So abashakashatsi icyo gihe baravuga bati kuki izi mpunzi nyinshi zavuye mu Rwanda ziri hano harimo abana bangana n'abaha bo abavukiye hano bakwirwara, abavuye handi mu Rwanda bakaba batari kwirwara. So ibyo byose byagiye biba, ntabwo twakita political question ahubwo cyitwa scientific question, cyatumye abantu batekereza. So baratekereza baravuga ati buriya nuko abavukiye hano nyine babaye exposed ku kintu mu gihe kinini, mu gihe abanyarwanda baje bo nyine bari barahandi hadafite iyo exposure. Nashaka ko Imana agira ngo ibarinde bazagire umumaro nko mu bihe nk'ibi ngibi. So nicyo cyabaye. So nyuma ubushakashatsi bukomeza bugaragaza ko ikibazo ntabwo ari Epstein-Barr virus yonyine, ahubwo bigirwamo uruhare na malaria. So recently bigaragara ko hari when we have a B lymphocytes, kuko Epstein-Barr virus ifata B lymphocytes cyangwa epithelial cells nizo infecting. So when a B lymphocyte which is infected by EBV igiranye interaction na red blood cell which is infected by Plasmodium falciparum, so niyo bihita bitanga noneho za mutations nyinshi. So niyo theory iriho ubu ngubu iri demonstrated. So I can say I also did research on that. So it is clear that malaria, especially Plasmodium falciparum malaria, has a big role to play in that. So icyo ngicyo kirahari. Ngira ngo noneho icyenda gukorwa ubu ngubu ni ukuvuga ngo ese ntabwo iyi malaria yaba ifite n'uruhare no muri acute lymphoblastic leukemia, kuko za B cells cyane cyane. Kuko na kare nababwiye ko research project yacu yabashije kubona bwa mbere ko na izo acute lymphoblastic leukemia zifite uruhare na EBV. Noneho mu cyo turi gushaka kureba niba na malaria itabifite mu Rwanda. So this is a research project we are starting. So I have already a few concurrents to conduct it. So we will collect samples and then analyze them. Molecular analysis will take place in Sweden, then other tests will be done here in Rwanda. So it means there are many things still to investigate about this. So the translocation between chromosome 8 and 14 is the most common. So here, MYC, you know, it is a transcription factor. It will be translocated ije ahari IgH, sorry, immunoglobulin heavy chain mutation kuri chromosome number 14. So iyo igezeyo rero umuntu akaba afite infection iri chronic nka malaria, ikibaho nuko kubera ko afite malaria azakenera gukora immunoglobulin nyinshi, ya transcription factor, transcription gene MYC nayo izaboneraho ikore cyane. Nikora cyane rero kuko kwishinzwe transcription nyinshi, habeho cell division nyinshi. Niyo mpamvu muri bacterial navuze niyo tumor yikura vuba vuba, habamo cell division nyinshi cyane. Nicyo kintu kibitera. So they have a very high mitotic index, but and a starry sky pattern on the microscope. inagiramo apoptotic bodies nyinshi nizo zituma habamo stare sky no kuvuga iki selile ziba ari ubururu cyane kwa ziri highly active in DNA synthesis hakaba izapfuye noneho zikaba engulfed by macrophages zigasa n'umweru so stare sky so sky ni ubwayo ni ubururu hazamo utuntu tw'umweru these tangible body macrophages are here bikasa k'akanyenyeri kari mu ijuru niyo mpamvu yise stare sky naho iyo jambo ryakomotse. So that's all for bucket lymphoma. So ikindi navuga nuko it responds very well to treatments given. Even here in Rwanda hari abana benshi barayikize. So muri rusange rero bizwi gufata abana average age ni 7 years. Abenshi ibafata kuri jaw hariya nko kuri mwana bimeze ariko hari bucket lymphoma tubona mu zindi organs. Even the one I saw once at Butaro in the ovary, arizo tubona muri bones, mu bwonko n'ahandi hose. So it varies. Ariko kubera kugabanuka kwa HIV AIDS, abarwayi ba HIV bajya muri phase ya AIDS kubera ko byagabanutse ubu ngubu bisa naho bucket lymphomas ziri kugabanuka. So yo ubwayo ifite many subtypes. We have the African form, which involves jaw as seen here. We have a sporadic form yo iba muri Europe cyane na hano besi tware tubona aba abdominal tumors akaba ni HIV AIDS associated. So these are the three epidemiological variants of bucket lymphoma. So half years or so as the translocation ariko izitewe na these Africans ones nizo 100% ni zazifite translocation. Hanyuma sporadic ntabwo ari 100%, zigira translocation ifata 8 ariko hari ubwo itajya kuri 14 cyangwa ajya no kuri 14 ugasanga exactly the area of the gene aho yaciriwemo aratandukanye. So ikindi nuko byaje kugaragara ko hari ibyatsi bimwe hari ibyatsi biteriye bucket lymphoma. I don't know its name, maybe I presented in neoplasia. Hari icyatsi so kinakoreshwa cyane nk'imitako muri za jardin abantu bakabitera ariko cyamaze kumenyekana ko nayo itera ibintu bisa na bucket lymphoma. Yango ni icyatsi kijya gusa n'imiyenzi hari nayo irimo birashoboka. So another thing I can say here nuko bucket lymphoma also sometimes has a leukemia counterpart. Uvuga ko hari usanga afite solid tumor ariko ukanasanga afite leukemic cells within the blood and the bone marrow. So diffuse large B-cell lymphoma is actually the most common form of non-Hodgkin lymphoma. It is very aggressive. It is high grade. So we have many serotypes. Yango muri iyo study dushaka kuzarebamo na malaria niki mbere twakoze kuri lymphoblastic leukemia tuzakora no cyane no kuri lymphoma. Hari lymphoma zizwi ko ziri more associated with EBV nizo tuzibandaho in plasmablastic niyo tuzareba cyane muri non-Hodgkin lymphomas. Noneho izindi tuzareba nizo muri Hodgkin lymphomas as we shall see. So Hodgkin lymphoma so yitiriwe Hodgkin ari bwa mbere. Ikindi musome ibitabo bya kera ntabwo wahitaga Hodgkin lymphoma, wahitaga Hodgkin disease. Bari barananiwe kumvikana niba ari lymphoma cyangwa niba just reactive infection or inflammation. So bayita Hodgkin disease. Ariko nyuma baje kwemeza bose ko ari lymphoma, it is a cancer, then ibitabo bishyashya ntabwo batandika Hodgkin disease. So hari there are cells which are characteristic iri hano bita RS, Reed-Steinberg cells. So na abantu babiri Reed n'uwitwa Steinberg bayivuzeho bwa mbere so barayitirirwa. Biba bisa naho hari amaserire abiri afatanya afite cytoplasm imwe, nucleus isa one is looking like another, like image mirror image. So they are positive to CD15 and CD30. So usually the class is antibodies. So they secrete cytokines. So these patients, they have B symptoms usually, chills, fever, weight loss, night sweating. They attract reactive lymphocytes, plasma cells, macrophages, and eosinophils. Ikintu cy'ingenzi aha ni ukurebonamo eosinophils. Iyo zibonyemo, wabonye izi red stem blood cells, it is very easy to confirm for us. This is a Hodgkin lymphoma. So the reactive inflammatory cells make up a bulk of tumor and they form the basis of classification. So bitewe n'uko reactive cells zingana, tushyiramo subtypes of Hodgkin lymphoma. And these are very important. So ibiri muri aka diagram hano nibyo byinshi nibyo by'ingenzi. So muri rusange twabonye ko lymphoma ibamo Hodgkin na non-Hodgkin. Muri Hodgkin rero tugiramo iyo bita classic Hodgkin lymphoma. Urabona ko arizo nyinshi, akabona nodular lymphocyte predominant. Iyi ngiyi ntabwo ifite red stem blood cells nyinshi, ifite duke cyangwa nta n'izuba. Icyo bitandukaniraho rero nuko nk'iyi nodular lymphocyte predominant igira outcomes nziza. Iyo ugiye muri izi classic rero nazo zirimo ibice bine none. Dufite nodular sclerosis, mixed cellular lymphocyte rich na lymphocyte depleted. Uko zikurikirana gutya, ibanza igira better prognosis, iya nyuma igira poor prognosis. So unfortunately iyi niyo ikuboneka, izo hasi izi poor prognosis zo ziboneka cyane mu bihugu bya Afrika. Izi nazo cyane cyane abafite HIV/AIDS, iya nyuma niyo bagira. It is very aggressive this one. Umurwayi ufite nabo kugira ngo akire n'indwara y'imiti ntabwo byoroshye. Mu gihe izindi they respond very well to treatment. By the way, igihe twaba Kaposi sarcoma ntabwo nibutse kubabwira igihe twayaga tuyibona Kaposi sarcoma ko na iri associated with HIV. Iyo umurwayi yahabwaga imiti ya HIV nubwo atahawe ya Kaposi sarcoma, yara cancer yararegressinga, yarashongaga. So that is a way of treating it we were using. Ko ntabwo bakorera surgery, hari ubwo bari byinshi abantu bamwe uri ahantu henshi utakora surgery. So we went to back. Okay. So the nodular sclerosis is the most common subtype of Hodgkin lymphoma, the classical type. So nyango nta bindi byinshi twavuga, nyango bindi nabivuze ni uko reactive cells ziba nkeya cyane cyane lymphocytes, uko dusanga zabaye nke niko prognosis y'umurwayi izaba nini. Iyo lymphocytes ari nyinshi biba biha amahirwe umuntu ko nubona azagira good prognosis. So this next part is the plasma cell disorder. So cancers arising from plasma cells. So we have hariyo bita plasmacytoma. It is here tubona afite one mass of plasma cells which are abnormal, of course, it is a plasmacytoma. Iyo tubona afite regions nyinshi ahantu hatandukanye, noneho yitwa multiple myeloma. But there are other characteristics as we shall see. So this is a malignant proliferation of plasma cells in the bone marrow. Nyango twayivuzeho tureba bone tumors. Navuze ko hari n'ituzabona muri hematopathology ni iyi ngiyi. Ubundi mu bihugu byinshi niyo iri the most common cancer affecting the bone. But in our settings it is not. Ntabwo tubona nyinshi cyane, turazibona ko ntabwo ari nyinshi cyane. So most common primary tumor for bone, as I said, but it is considered as a metastatic cancer. Plasma cells, they don't normally live in the bone marrow. Kirango murabizi uko bigenda. Blood cells, they are formed in the bone marrow. T lymphocytes will mature in the thymus. B cells will mature in the bone marrow, but plasma cells will mature on the periphery. Nukuba muri tissues and muri blood niho zibera mature, niho B cells zandikiramo plasma cell. So kuzibona muri bone marrow rero kiba ari ikibazo. So these patients will have a high serum interleukin 6, which stimulates plasma cell growth and immunoglobulin production. So ikindi kibanga bibakoreye x-ray iyo ubikese ugakora x-ray usanga afite lytic lesions amagufa yaba y'umutwe n'ahandi usanga harimo ahantu henshi hari dark, so there is no calcium, there is the lytic lesion, osteolytic lesions, many of them. So when you see this, then say these are the punched out lesions on the X-ray, which should show that probably this is a neoplasm. So that is one. And there will be bone pain and hypercalcemia. When you have bone pain, there is a destruction of the bone, and then because of that, calcium is being now released into the bloodstream. That's why there is hypercalcemia. So stochast, they do bone destruction and so on. So lytic punched out skeletal lesions are seen there. So especially the vertebrae and the skull, they are the ones which are more affected. Our increased the risk of fracture. Ngira ngo muri na clinically ni umurwayi ugomba kwitonda yibiketse. So last time the hematologist worked together at Sashika, so twari kumwe ari gukora bone marrow biopsy, so avuga ngo ingo ndabona ari multiple myeloma. Iyo ari multiple myeloma uhita uyumva winjiza urushinge ukayanga kubinjiza nko mu bishashara cyangwa ibintu byorohere, kandi undi bone bikomeye ungizamo igishinge bisaba imbaraga nka tekinike ngo cyinshi, ariko iyo harimo multiple myeloma kiba cyaba n'ibintu by'ibishashara by'ibyatsi byumye ku buryo winjiza urushinge kumva muri kwijyana. So they have elevated serum protein, especially immunoglobulin. Immunoglobulin ibiri hejuru bituma kuri electrophoresis, narayize electrophoresis. Ahangaha iyi plate, iyi electrophoresis hano iri kwerekana in green what is normal. Murabizi ko mu maraso albumine niba ari nyinshi, akanyuma hakaza utudukeya alpha 1 and alpha 2 globulin, hakaza na beta globulin iba izamutseho gake, na gamma globulin iba ari nkebe. Ariko iyo ari umuntu ufite multiple myeloma, gamma globulin murabona ko yazamutse cyane, the rate is abnormal. So this is what happens. So bavuga ko afite M spike ari nuko byanditse nk'inyuguti ya M is present on serum protein electrophoresis, and this is most commonly due to monoclonal IgG or IgA. So nuko ko umurwayi ntabwo azagira IgA na IgG byose bizamuka cyane. Because it is a monoclonal disease, it must show one type of immunoglobulin. Ibyo dupima nko muri histopathology tuba ko ari monoclonal, tureba niba afite izi immunoglobulin ze afite right chain, niyo tureba ese right chain afite ni lambda cyangwa ni kappa. Iyo afite byombi ntabwo bikibaye multiple myeloma, kuko icyo gihe byabivuga ko ari polyclonal. Ariko iyo ari multiple myeloma dusanga either afite kappa gusa cyangwa se afite lambda gusa, right chain. So the clinical features, so we continued because others are presented here. We have increased risk of infection, where gamma globulin yafashaga kugabanya infection iba yagize izaza ari abnormal. Rural formation of red blood cells on the blood smear, and the primary AL amyloidosis. So remember amyloids, so it is of many types. So kubera free light chain proteins, there are very many in this case, too much, so they are be deposited in any tissue, including bone marrow. Another feature is proteinuria, because this free light chain protein will be excreted in urine. Icyo gihe babita Benson-Jones protein. So iyi ni kimwe mu bintu bigomba kwemeza ko umuntu afite multiple myeloma. Otherwise iyo muri histology tubona biriya byose, ariko kuri urine ntitusange afite Benson-Jones protein, icyo tuvuga ko ari plasmacytoma, ntabwo twemeza ko yamaze kugera multiple myeloma. So there are many others. Go monoclonal gammopathy of undetermined significance. So umuntu aba afite increase the serum protein with M spike on SPEP, so that is serum protein electrophoresis. Ariko ugasanga ibindi biranga myeloma ntabwo bifite, ntabwo afite lytic bones, ntabwo afite hypercalcemia, ntabwo afite Bence Jones proteinuria. So another one is the Waldstrom macroglobulinemia, B-cell lymphoma, which produce too much IgM. So there are generalized lymphadenopathy, lytic bone lesions are not there. There will be increased serum protein with M spike, which is composed of IgM, mu gihe muri multiple myeloma ni IgA or IgG. So there are other deficits here. So acute complications are treated with plasmapheresis, which removes IgM from the serum. So we end with Langerhans cell histocytosis. So Langerhans cells ubwazo zimeze nka macrophages, but so histiocyte of course. Histiocytes ni kimwe na macrophage, nuko macrophage iba yarakoze when it has engulfed things, niho bakunda kwita macrophages. So Langerhans cells are specialized dendritic cells predominantly found in the skin, so not macrophages. Macrophages ni histiocytes, not Langerhans cells. So these are dendritic cells derived from bone marrow monocytes, ariko birumvikana ko zose ziva hamwe. Ari monocyte, ari Langerhans cells, ari histiocytes, cyangwa byose biva muri monocytes. They present antigen to naive T cell, nyango cyaje ture ibintu bya allergy kuri skin na hari ibyo twerekanye uko ifata antigens y'ibintu byafashe nko ku ruhu ikazereka T cells, then that T cells zigakora activation of many things. So Langerhans cell histiocytosis in neoplastic proliferation of Langerhans cells. So characteristic Birbeck or tennis racket granules are seen on electron microscopy. So cells are CD1A positive, S100 positive. Izi markers S100 turayigira Africa. CD1A you don't have it. So it means sometimes we are challenged when we want to diagnose this. Ariko hari indi dukoresha twa CD68 isimbura iyi, which is a marker for monocytes and macrophages and so on. So the lateral sewer disease, the result, it is also another type of proliferation of Langerhans cells. So the patient presents with skin rash, uduheri twinshi, cystic skeletal defects usually it affects infants, not adults. Yeah, the Langerhans cell histiocytosis affects adults. So eosinophilic granuloma, there is a benign proliferation of Langerhans cells in the bones, and usually this patient will have fractures, but the skin is not involved. So understand that it is a benign proliferation. So although it is called eosinophilic, it has no eosinophils, but it is reddish. That's why it is called eosinophilics. So Hand-Schüller-Christian disease, it is another malignant proliferation of Langerhans cells. So they have skin rash, lytic school defects, diabetes insipidus, and exophthalmos. So and binafatanye, and exophthalmos ni ukuvuga amaso asa nazi imbere turumuka, it is seen in children. So you see that it is almost the same as sewer disease, that also has Langerhans cell histiocytosis, bitandukanywa n'ibindi bintu byongera nk'ayongeho diabetes and exophthalmos. So that's all for this chapter, and that's all for theoretical component of systemic pathology. So we have, as I said in earlier, we have so far covered everything in medicine, the basic about the diseases in humans. So it will be up to you to make use of the knowledge acquired from here, because if you make use of it very adequately, you will be good doctors. If not, then you will be something else. So it will be up to you. So, and I'm glad that I have covered all chapters that we had to cover. In the previous years, it has been problematic. Hari byatewe nuko muri iki gihe hari gahunda nyinshi na inama nyinshi n'ibindi bagiye bamenya kujyamo nkanga kubijyamo, because I wanted to cover these things, especially that I was on leave. So it is like the first time we cover everything in systemic pathology and far free. So I hope you will benefit from that. So the timetable shows that the lectures of systemic pathology ends next Friday. So this means that Monday and Friday we'll have practicals in the lab at Ruhande campus, you know, where there is a pathology and histology lab in the main campus. So you will have you will do arrangement, with example, at to Isenge and Prosper, to know how you will rotate there. So I was talking to them just during the noon break. So you will do arrangement. There are many stations or yes, stations or sessions to do there. Hari ukumenya icyambere uko lab ikora, ibikorwamo n'uburyo bikorwa. Hari ukureba gross specimens. We have a gross specimens of many diseases, cancers, stomach, so igifu ugasanga ari igifu cyose, ibere, uterus, so byose birahari. Most of them they came from CHUK, and there are slides prepared, some locally, others abroad, from abroad, zafasha just to identify regions, so, and many other things. So you will make arrangement, or we will make arrangement on how you will rotate there in smaller groups on Monday and on Friday, and you will also remember to sign your attendance there. So if you have any questions, any comments, it is a time for that. So otherwise also you will have to tell me about your continuous assessment, because when you started the module, you said you want many. So when I proposed to you to have the first ones, you said you are not ready, this one to now have done one, and the one assignment you will have to submit. So you will tell me what you propose. Thank you very much.